Good evening, viewers. On behalf of Doc Places, I am Kajal Mukherjee. Welcome you to today's podcast. Polycystic Ovary Syndrome, or PCOS, is a hormonal disorder that commonly affects women of reproductive age. It often leads to irregular menstrual cycle and cause missed or heavy periods. Many women with PCOS experience weight gain, acne, and excessive hair growth on the face and body. The condition can interfere with evolution, making conceptions more challenging. We'll gain deeper insight into this subject with expert reproductive medicine specialist, Dr. Ankita Srivastava. Ma'am, welcome you.
Thank you.
So, Dr. Ankita has completed MBBS, MS, DNB, FMAS, and currently doing residency in MCH in reproductive medicine and surgery from Amrita Institute of Medical Science, Kochi. So let us start the journey of medical interactions. Ma'am, you want to give a brief introduction? You can go through.
Okay. So PCOS basically is a multi-system disorder wherein we have endocrine metabolic disorder as well as it affects the cardiovascular system later on. So what we have to make sure is that we have to have lifestyle modifications and early recognition of the symptoms and so that we can control it. And we have to understand the prevalence. It is about 8 to 10%, and it is increasing now. It is more in the infertile population. Now, infertile population has about 20 to 30% anovulation. And in that anovulation, PCOS comprises about 80 to 90%. Only 20 to 30% patients will have a PCO morphology on ultrasound. Rest will not even have a PCOS morphology. And that is why early recognition is so important in this condition. And an index of suspicion is so important in this condition.
Thank you, ma'am. Thank you for your introduction. But even at the cost of repetition, to start with the basics, I will just put one question. What exactly is PCOS and why it is considered such a common endocrine disorder among women today?
So PCOS basically is polycystic ovarian syndrome, wherein we have a chronic inflammatory background and we have a metabolic disorder, which is a component, and an endocrine component. Now let's understand the pathophysiology and let's dive deep into it. What exactly happens? This is starting from the fetal arena, fetal hypothesis there, LH hypothesis there, and ovarian hypothesis there. So these are the three hypotheses of why PCOS has come into play. And we'll be discussing later on also about the genetic aspect of it. So all these together form a PCOS milieu. Now, in the fetal aspect, it is also known as the Barker's hypothesis, wherein if the maternal androgens are high, that exposes the fetus to hyperandrogenemia. And because of high androgen exposure during the fetal life, this creates an hyperandrogenic environment. LH increases, testosterone increases. I will explain how exactly LH. Remember right now that in PCOS, LH is high, testosterone is high. I will explain you the whole cycle of why it happens. So LH increases, that in turn increases testosterone, and high testosterone further increases more LH. So it is a vicious circle. So all this again causes a hyperandrogenic environment. Maternal exposure was there, then the fetal mechanism also starts bringing in hyperandrogenemia at the fetal level. This will increase the insulin levels because the androgens will stimulate insulin production. That also I'll explain how it happens. Hyperinsulinemia is always there from the fetal point. Fetal part only starts and then hyperinsulinemia, hyperandrogenemia, that starts. So these predispose to PCOS. And when we talk about PCOS pathophysiology, basically what happens? Androgens are responsible for recruitment of follicles. So when androgens are high in our body, more follicles get recruited. And that is why we have a polycystic ovarian syndrome, or a picture of multiple small cysts like follicles, which are not really cysts, but they are small follicles, which gives an appearance of polycystic ovaries.
So thank you, Dr. Ankita. Just to ask you, how has the understanding of PCOS evolved in the recent years? Means, are we still learning new aspect about its causes or management?
Yeah. So the entire classification has also got a lot of evolution. So earlier NIH was saying that we only need two criteria, which is clinical or biochemical hyperandrogenism or oligo or amenorrhea. Okay, so these were the two criteria which NIH was saying in 1990. Now then Rotterdam criteria came, wherein 2 out of 3 criteria were enough, which was clinical or biochemical features of hyperandrogenism, oligomenorrhea or amenorrhea, or features of anovulation being the second, and third being the PCO appearance on ultrasound. So out of these 3, if 2 were present, that is okay for Rotterdam criteria to define it as PCOS. And Androgen Excess Society was saying that you have to have features of androgen excess, and along with that you have any one other criteria, which could be PCO morphology, PCO appearance on ultrasound, or features of anovulation. So Androgen Excess Society says that at least you should have one feature of androgen excess, like hirsutism, acne, all that, or biochemical hyperandrogenism should be demonstrated to classify it PCOS. And now we are saying NIH 2012, which has collaborated with ASRM and ESHRE 2003, and defined that either you have 2 out of 3 criteria as we defined in Rotterdam's features of hyperandrogenism, clinical or biochemical features of a hyperandrogenism, features of anovulation like oligomenorrhea, amenorrhea, or PCO appearance on ultrasound, and you have to be able to identify in which specific PCOS phenotype this patient is falling. So that is also very important. So we define it as PCO phenotype A, B, C, and D. Phenotype A will have features of all 3: hyperandrogenism, ovulatory dysfunction, and PCO morphology on ultrasound. All 3 will be present in A. B will have hyperandrogenism as well as ovulatory dysfunction. And C will have hyperandrogenism and PCO morphology. Okay, ovulatory dysfunction is not included in morphology C. That's why we call it ovulatory PCOS. So category C, morphology C, is known as ovulatory PCOS. And category D is the one which is having ovulatory dysfunction and PCO morphology. So features of hyperandrogenemia are not there in category D.
Thank you, Dr. Ankita. So, what are the most common symptoms women with PCOS experience, and why do they often go undiagnosed for years?
Okay, so the commonest symptoms are there could be menstrual irregularity. Menstrual irregularity could be there. Some people may have heavy bleeding because of anovulation. So when we start from menarche, during menarche, the first 1 or 2 years, the cycles are irregular. So that is why we don't even define PCOS until the first year after menarche. So the newest ESHRE guideline has clearly given definition of PCOS as after 1 year of menarche, you have to see. If she is after 1 year and she has not had a period for 90 continuous days at any time, then you can define it as PCOS. Second thing is between 1 year and 3 years, if her cycle has gone beyond 45 years or less than 21 years, these are irregular cycles we are defining. Then after 3 years, if the cycle has gone beyond 35 days and less than 21 days, okay, and or less than 8 cycles per year. So these are irregular cycles. And in the beginning, when there is an adolescent, we may have a picture of polycystic ovaries or a multicystic ovaries on ultrasound, which could be normal also. So about 20% will have this picture of PCOS on ultrasound, but they will not have any features of ultrasound. So we have to be very, very careful. That is why the diagnosis could be missed, because adolescents or in the early part of their menstrual career, the cycles are anovulatory, the cycles are irregular. So it could be a physiological thing, or it could be an early sign of PCOS as well. So what, and AMH at that point is also not reliable marker according to the newest ESHRE guidelines. So we need not do AMH in adolescents at all. So that will not give a reliable marker. And multicystic ovaries are basically because there is anovulation, patient is not ovulating, so multiple cysts are being formed. So that is why it has to be distinguished between a PCOS ovary and a multicystic ovary. There are other features also. Because of hyperandrogenism, there could be acne, there could be hirsutism. And why are these there? Because the testosterone, which is high in the body, gets converted into dihydrotestosterone. Okay, so these stimulate the keratinocytes, the skin thickens. That is why all these changes happen. Hirsutism can be there because of high 5 hydro, because of 5 alpha reductase activity, which increases, and we have more of dihydrotestosterone. Acne will increase, then because of testosterone, hirsutism will increase, and then also we have acanthosis nigrans. Acanthosis nigrans is because the keratinocytes are stimulated and they cause thickening of the dermal layer and epidermal layer, and that is why we have the hair-on syndrome in the hyperandrogenism, insulin resistance, and acanthosis nigrans in PCOS.
So, ma'am, you are talking about we missed the diagnosis sometimes. So there is an often confusion between PCOS and other conditions like endometriosis or maybe thyroid disorder. So how is PCOS actually diagnosed today?
So PCOS is actually the diagnosis of exclusion. So we have to rule out other causes of anovulation. So now we talk about the FIGO classification of anovulation. We have hypo-P classification. Okay, so in first we have the hypothalamus. Hypothalamus will include maybe the physiological or tumors or idiopathic causes. Then we have the pituitary, where the anovulation is at the level of pituitary. Or there could be anovulation at the level of the ovary itself. So these three could be there, and then PCOS will also be there, one of the features in the anovulation. It will cause anovulation. So that is how we have to make sure that we first rule out all other causes of anovulation. We have to rule out late onset congenital adrenal hyperplasia. We have to rule out hypothyroidism, hyperprolactinemia, which could also give rise to irregular menses and anovulation. And then we have to rule out any other tumors or any other markers. We have to rule out any other chemotherapy or any other history that we might be missing, and then only come to a diagnosis of PCOS. And endometriosis will give features related more of dysmenorrhea, or chronic pelvic pain will be there, or it could have dyspareunia. So that is on the basis of symptoms we can rule out endometriosis in our patients.
So since we are talking about the differential diagnosis, so apart from the differential diagnosis, the diagnostic criteria do also differ across region or guideline. Like you are talking about Rotterdam versus NIH, and how does that affect patient care?
Because we have to make sure that we are not missing anything. It's a diagnosis of exclusion. We have to rule out everything else. We have to see if the hirsutism has any other cause. We have to make sure that we are not missing any other, features of androgen excess. If the androgen excess is happening suddenly, we may have to do other tests also. So whenever we have PCOS, she is predisposed to type 2 diabetes, she's predisposed to hypertension, cardiovascular diseases, hyperlipidemia. So whenever at the first diagnosis, we have to do a fasting blood sugar, postprandial blood sugar, and HbA1c. We have to do a blood pressure, and we have to also do a lipid profile. So when we first meet her, this is what is to be done. And if it is normal, then it has to be repeated annually so that we do not miss, because these are predisposing to having diabetes, hypertension, and cardiovascular disease, endometrial CA. So all these have to be monitored first at the first visit and then annually after that if it's normal.
So you are talking about different diagnostic process, blood test. So what the role do blood test or ultrasound and clinical evaluation play in confirming a diagnosis of PCOS?
So PCOS, now the newest guideline says that you do not need an AMH if you have an ultrasound picture of PCOS. So if you're sure with your if you're sure with your ultrasound that it is PCOS, you don't need to rely on your AMH at all. Otherwise, we do get an AMH. Plus, we'll see that LH levels are high. Why that happens, that I'll explain to you now. And also the androgen level, the DHEAS level, which is quite sensitive, that is also increased in PCOS. Sex hormone binding globulin is reduced in PCOS. So we'll see, because now what happens, we have high androgen in our body. So many follicles are recruited. Now all these will start producing estrogen. Okay. And therefore there will be a hyperestrogenic environment. Here also what we'll see is there is tonic release of LH. It is not pulsatile. It is tonically increased LH level. So and FSH is not so high. So LH FSH ratio is disrupted. So that is one thing. The FSH LH ratio is disrupted. Second thing is that because androgens are there, small follicles are coming in and they are all producing estrogen. LH level is high. So premature luteinization of the follicles are happening. Premature luteinization is happening. So therefore, when we also stimulate the patient, we may have oocyte quality issues because these patients are going in for premature luteinization because the body's inherent LH level is high. That is one thing. Now, second thing, patient is not ovulating because there are so many small follicles, but no follicle is able to cross the FSH threshold and be selected as a dominant follicle. That's why ovulation is not occurring. So since she is not ovulating, therefore what is happening? She is not having a corpus luteum, progesterone is not being secreted. Progesterone is the one that has feedback inhibition to LH. Now progesterone is not being secreted, so LH feedback is disrupted. So again, LH is rising high. So that is one reason why LH is rising high, because we do not have enough progesterone. Third thing is that because LH is high, testosterone is high, they cause theca cell hyperplasia. And this causes hyperthecosis, or the stroma is thickened in PCOS and causes a lot of resistance among the follicular development. It also affects the oocyte quality. Fourth thing is that because it is this tonically high LH, what it will do, androgens will be there. It will prevent any feedback from progesterone to LH. So androgens being high will increase LH. LH being high will increase androgens. So a hyperinsulinemic environment will be created, and that will predispose to all the symptoms of PCOS.
Dr. Ankita, we have heard that PCOS is often linked with life cycle changes. So how much of it's of genetic versus influenced by environment, like environment, diet, and stress? What is your opinion?
So genetic, it has a major component. Genetic, it is there are various genes which have been implicated with this. So it could be autosomal dominant, also X-linked. So there are various types of polygenic inheritance we are seeing. Okay, so when we see it running in families, we also see that, and the newest ESHRE guideline also states that if a patient has PCOS, we have to examine the mother as well as the sister. There could be correlation, plus the brother, because they could be predisposed to cardiovascular disorders. So that is the family tree we need to keep in mind when we are seeing our patients, because the brothers, the male family members are also predisposed to the cardiovascular aspect of PCOS. Now, as I told you, hyperandrogenic environment in the mother will predispose to hyperandrogenemia in the baby, in the uh, fetal part only. There are other genes which have been implicated, genes related to steroidogenesis. We have the cytochrome P17, aromatase P450, all these are implicated. Plus, at the ovary level, we have follistatin. All these genes are also affected. Plus, there are hunger suppressing genes, obesity genes, those are also implicated. We have PPAR gamma gene, which is affected. And we also see that at the hormonal level, GLP-1 is present in our gut, which is the appetite suppressing hormone. So in PCOS, that is affected, and therefore appetite suppression is not there. Ghrelin is affected, leptin resistance comes. Leptin is responsible for hunger suppression. So leptin resistance will prevent hunger suppression. So patient is not feeling the satiety and patient is feeling hungry because of all these factors that are playing a role.
So, what is the connection between insulin resistance, weight gain, and PCOS? So, normally there comes a question that can lean women also have PCOS?
Yes, lean women also have PCOS, and we see that like anovulation is also seen in lean women. Now, lean women, what happens is they have high LH level. That is very important. That is the main predisposing factor. They have high LH level, and hyperinsulinemia. When we're talking about it related to obesity, it is a vicious circle. Hyperinsulinemia, hyperandrogenism, which we have so deeply spoken about in PCOS. Now, this will cause abdominal obesity. It will cause insulin resistance. Now, insulin will be there in the body, but the body will not recognize it. So, the metabolism will be slowed down. Gastric emptying time will be slowed down. So, gastric emptying time will not be slowed down, which is supposed to be done by GLP-1.
Yes.
Gastric emptying time will not be slowed down, and so she will keep feeling hungry. She will keep eating also, and the metabolism will not go on as required. The metabolism will not be fast, and therefore there will be abdominal obesity, which will predispose to more hyperinsulinemia and hyperandrogenism. So that is the vicious circle. So we have seen that even just 5 to 10% of weight loss will bring back the menstruation, will bring back the ovulation, and even lead to fertility. 500 kilocalories, if it is reduced from the diet for about 6 months, that can cause ovulation and fertility. Also, exercise is to be done. So if we are talking about vigorous exercise, 120 minutes in a week is enough. If you're talking about moderate exercise, 150 minutes a day is enough. 150 minutes a week is enough. And we also have to make sure that strength training and weight training is done, because that increases the muscle mass, reduces the fat mass. Increasing the muscle mass increases the basic metabolic rate, the basal metabolic rate, and it also stimulates the the hyperandrogenemia and hyperinsulinemia is reduced. The reduction of hyperinsulinemia takes place if the muscle mass increases and the metabolic rate increases.
Thank you very much. So, I'm coming to another important aspect. How does PCOS affect fertility? And what are the latest advancements in helping women with PCOS conceive naturally or with assistance?
So when we talk about fertility, as we have explained, that the follicles will not develop, so ovulation will not take place. So once there are small follicles, they are not crossing the FSH threshold, and there is premature luteinization, so oocyte quality is hampered. That is one thing. Second thing is at the granulosa cell level also, because there is hyperandrogenemia, because the environment is hyperandrogenemic, And this will also affect the oocyte quality. We need myoinositol and D-chiroinositol in our body. Now, myoinositol is present in 99% in our body, and D-chiroinositol is present in 1% in our body. So this is a ratio that needs to be maintained. In PCOS, what happens? This ratio gets derailed. Now, myoinositol, what happens is that it is helpful. There is an IP3-DAG pathway wherein oocyte maturation takes place. So if myoinositol is not there in adequate amount, oocyte maturation, nuclear and cytoplasmic maturation is affected. And D-chiroinositol, which is there in 1%, that is required for the peripheral aromatization. Okay, so now there is an enzyme in our body, epimerase, which converts myoinositol to D-chiroinositol. In PCOS, this epimerase enzyme goes higher. So more of myoinositol gets converted into D-chiroinositol. We needed 99% of myoinositol and 1% of D-chiroinositol, but now we get more of D-chiroinositol. So that is affecting the ratio, the normal ratio. And that is why oocyte quality issues, oocyte maturation issues occur, and follicular genesis is affected in PCOS. This is about being the follicles. At the level of endometrium, now when we are talking about fertility, follicular genesis and giving good oocytes is one thing. And once we have a good embryo, we also need to make sure that it implants. With PCOS, during the implantation window, we see that glycodelin, which is an implantation supporting protein, and HOXA1 gene, which is an implantation affecting protein and gene again. So all these are down-regulated in PCOS. So it is not only affecting the oocyte quality, follicular genesis, it is also affecting the endometrial receptivity and implantation. So all these lead to PCOS infertility.
Thank you. So beyond birth control pills and metformin, what new or alternative treatments are emerging for PCOS management?
Okay, so I'll briefly tell about the mechanism of each. So we have the birth control pill, which is for regularizing the cycle. And in previous studies, it has also been seen that PCOS, if it's given for about 2 to 3 months, it is reducing the resistance and it is reducing the OHSS rate when we are stimulating the patients. Why is that? What is the mechanism of birth control pill helping in PCOS? Now in PCOS, we have high testosterone, high androgens. So birth control pill will reduce the androgen level. That will help with the oocyte quality. Second thing is that estrogen component of the birth control pill will increase the sex hormone binding globulin. So the sex hormone binding globulin will increase and it will bind with the free testosterone, and free androgens will be less in the circulation. So all these will help in the maturation, follicular maturation, as well as the oocyte quality, and it prevents OHSS. And the Cochrane study was done in 2017, which said, which I will come to later on, but the newer guideline, the controlled ovarian hyperstimulation guideline, is telling now that if you give more than 10 to 12 days of OCP, it is affecting the oocyte quality. Again, the mechanism that they're implicating is that the androgen level is going down too much if we are extending beyond 12 days. We need some amount of androgens in our body to have good follicular genesis, and it is important to maintain the balance. So that is why the newest guideline is saying that pre-treatment with OCP should not be done beyond 12 days, because that is affecting the oocyte quality. Okay, so that is about OCP regularizing the cycle. Second thing is that metformin. Now, metformin is a biguanide. Why it is helping us? It is reducing the glucose in our body. How it is doing that? First of all, it is reducing the gastric absorption of glucose. It is reducing the hepatic uptake of glucose. It is increasing the skeletal muscle absorption of glucose. Skeletal muscles, liver, everything will absorb the glucose more. So all these mechanisms, which we start with 500 and go up to 500 OD and then go up to, in a graded manner, 500 TDS, which can have some side effects of GI effects or lactic acidosis, but we have to make sure that we explain to the patient. Now, the Cochrane review in 2017 told that metformin is regularizing the periods and is increasing the live birth rate, but the newest guideline is saying that you give metformin to prevent OHSS. For the prevention of OHSS, only in the antagonist cycle in the indicated case, only in the agonist cycle in the indicated cases. Antagonist cycle do not need metformin for prevention of OHSS. So that is about metformin. Now, other things are that you can give myoinositol. I explained the mechanism why we need myoinositol. It scavenges the reactive oxygen species and helps in good follicular genesis, and oocyte quality is improved. Then vitamin D supplementation has also improved the effects. Then we have antioxidants like L-acetyl, N-acetylcysteine. These are also, these scavenge the oxygen species, reactive oxygen species, and give good results. So these all can be given in PCOS.
So, Dr. Ankita, you are talking about diet also plays a role in PCOS. So, are there specific diet like low GI, intermittent fasting, or anti-inflammatory diet that are showing any promising result in PCOS management?
So basically, the guideline, the newest guideline defines Mediterranean diet as the newest diet. But we have also seen mention of Atkins diet and low glycemic index diet also. So Mediterranean diet, I'll just stick to the guideline what it's saying. So the Mediterranean diet is basically you include fruits and vegetables in your diet every day. Every day you include fruits and vegetables and some proteins, nuts. You make sure that all your food is cooked in extra virgin olive oil. Then you can include every 2-3 days a serving of chicken or eggs if you're non-vegetarian, or vegetarian like legumes, dals, that you can have the protein intake. The soya, you can include that. You have to reduce the sugar intake and the red meat intake completely to at least, you reduce it to at least just once a week, so that all these hyperinsulinemia is and the insulin spikes are avoided, and include more of antioxidants. We can have the seeds, the flax seeds and all the seeds that we are hearing about. You can include that, and you include yogurt because they have the friendly bacteria that we need. So they will help in the gut microbiome development and maintenance. So that is the Mediterranean diet, and you concentrate more on the fibers in the diet and the proteins in the diet. In the low glycemic diet also, we reduce the carbohydrate component and reduce the fat component, increase the protein component. Because if we just reduce everything, then that will reduce the muscle mass also, which we don't want. We want the muscle mass to be maintained so that the basal metabolic rate can be maintained.
Thank you, Dr. Ankita. Now, what today's sessions you are doing are actually you are increasing awareness about PCOS. So, with increasing awareness and healthcare, are healthcare providers now better equipped to provide holistic care, including mental health support for women with PCOS?
Yes, because now we have a multidisciplinary approach. Even with our patients, when the PCOS patients are coming, we are counseling them properly, and then we are getting a full multidisciplinary management. We have the dermatologist, we have the psychologist, psychiatrist, if needed, if there's anxiety, depression, because it can help them, it can affect the mental health as well, and the gynecologist. They're all working together and having a multidisciplinary approach. So awareness has increased, and we're also telling them that what are the fertility options and what are the options when fertility is not required. And we're also telling them about the long-term effects. So the cardiovascular surgeons are also included, the cardiologists are also included in our management, the endocrinologists are also included because it can predispose to diabetes, and all of us together are looking at PCOS patients in a more holistic way.
So, ma'am, we are now coming to the closer to this session, but I will certainly ask a futuristic question to end this session. So, looking ahead, we breakthrough in research, technology. This could significantly improve the way of PCOS, how it is diagnosed and treated in the next decade. So, what is your opinion?
So the newest drug which is coming up is the GLP-1, glucagon-like peptide receptor agonist. So that, as I explained, this is the hunger suppressing hormone, and this supplementation is causing weight loss, regularizing the menstrual cycles, and also helping in ovulation. But we do not have safety data for the category of drug that it is yet. So we have to make sure that she's not looking for conception. And when we are giving her GLP-1, we have to make sure we give her contraceptives. And that is the take-home message. If you're giving GLP-1 to a patient, give her contraceptives, make sure she's not trying to get pregnant at that time, because we do not have long-term safety data and safety in pregnancy data yet. But that is a promising new thing, new drug that is coming up.
With this, Dr. Ankita, we come to the closer of the session. So I once again take this opportunity to thank you very much for your precious time and especially your expert inputs into the important subject like PCOS. I think those who are going through these sessions, they must have taken some takeaway points, which will certainly help into their future treatment process. Those who have missed these sessions, important session from Dr. Ankita Srivastava, they can watch it on our recorded version, which we'll put after 24 hours on our platform. So, and also we will come out with more important sessions like this. So just follow Doc Places platform. Thank you very much for your support. Ma'am, to end with, any one-liner message from your side?
So this is the PCOS Awareness Month we are celebrating. So we should make sure that we spread the awareness and treat our patients with empathy, because that is what we all need at the end of the day.
With this, we close this session. Thank you very much, ma'am. Thanks for your time.